Hi, my name is Brittany E. I'm a medical student at UC San Diego, and I'm here at the Kidney Week for ASN presenting my poster on in-hospital and long-term management and outcomes of acute kidney injury. So our study was a retrospective case control study where we evaluated the inpatient management, complications, as well as the long-term outcomes of patients with and without acute kidney injury based on ICD-9 codes. So the methodology that we followed was we reviewed the charts of 100 patients who had ICD-9 codes for acute kidney injury, and we compared them to a matched cohort of 190 patients who did not have ICD-9 codes for acute kidney injury. We took a look at their charts for prior histories of end-stage renal disease, kidney transplant, dialysis, and excluded those from our studies. And then we confirmed AKI events by looking at the AKIN criteria or modified AKIN criteria. So taking a look at our results, looking at patients with ICD-9 codes for AKI, you see that 100% of them did indeed have acute kidney injury events, 38% by standard AKIN criteria, 62% by modified. And what was interesting to us was that of those patients who did not actually have ICD-9 codes for AKI, a whole 26% of them actually did have AKI events. So this reaffirms what we've seen in the literature, that ICD-9 codes aren't always a reliable means of diagnosing patients with AKI. We also took a look at the incidence of fluid overload, sepsis, dialysis, length of stay, and in-hospital mortality, and many of those showed statistically significant increase of rate of complications among those patients with ICD-9 codes for AKI. Taking a look at the in-hospital management, you see that patients who got the ICD-9 label more typically received urinalysis, electrolyte studies, strict INOs, and more often had their medications renally dosed than those who did not have ICD-9 codes for AKI. Looking at the outcomes at 1 year in all of our patients who survived their index admission, you see that patients who had ICD-9 codes for AKI typically had better follow-up with nephrology and more often progressed to end-stage renal disease and had subsequent acute kidney injury events. So in terms of our discussion and why this paper is important, we see that patients just need to be diagnosed earlier, have interventions more quickly done, and better follow-up. And I think this will really help in terms of the long-term outcomes of patients with acute kidney injury. Thanks.